Okay, good evening, colleagues, ladies and gentlemen. I think we are now a quorum to begin our CME for the evening. My name is Winnie Mwebia. I'm an obstetrician gynecologist in Embu. And I'd like to take this opportunity to welcome you all to the CME of our CME this evening. It's on family planning options, titled Contraceptive Options, What's Best for Who? This is a question that we often encounter when women come to our clinics. They ask us, Daktari, which is the best family planning for me? Do we really have a best? That's a question that our presenter, our facilitator for this evening will help us answer. And this CME is courtesy of Kenya Obstetrical and Gynecological Society Central Branch, hosted by KMA. And our sponsors for the evening is Mary Stopes International. So I'd like to take this opportunity to welcome our presenter for this evening. That's Dr. Grace Kanyi. Dr. Grace Kanyi is an obstetrician gynecologist at Marimanti Level 4 Hospital in the Tharaka-Nithi County. She's an alumni of School of Medicine at the University of Nairobi for both her undergraduate and postgraduate studies. She's worked as an obstetrician gynecologist in both public and private sector, where she aims to improve on the quality of maternal care through adoption of evidence-based medicine and fostering strong teamwork. Dr. Kanyi has several publications and it's my honor and pleasure to welcome her to take over. Karibu, Dr. Kanyi.
Thank you so much, Dr. Winnie Mwebia. For some reason, we almost always tend to introduce each other during these presentations. And thank you everyone who has joined in on this call as we participate or go through today's presentation on contraceptive options, what is best and for who. As I've rightly been introduced, I am Dr. Grace Kanyi, an obstetrician gynecologist at Marimanti Level 4 Hospital, which is in Tharaka-Nithi County. So to dive us into the first part of the presentation, we'll start with some definitions and some statistics. So family planning, which is literally what it's called, contraception, can be used to plan when women and couples want to have their children, how many children they wish to have, and the birth space in between their children. It is by using family planning methods that we can be able to reduce pregnancy-related risks and therefore reduce cases of unsafe abortion, which contribute significantly to morbidities and mortalities worldwide. In addition, it will also help in reducing teenage pregnancies, where majority of those pregnancies are unwanted and most of the times end up with unsafe abortions. We do know these are girls that we need to keep in school, and these early pregnancies impact negatively on their relationships and ambitions. In addition, family planning helps in helping couples and women bring forth healthy babies, because they'll be getting these children at a point in time when they are ready. And this is ready being, physically, emotionally, financially, all round. And indeed, the provision of family planning is one of the 6 pillars in provision of safe motherhood, the others being quality antenatal care, quality obstetric care, quality postnatal care, comprehensive post-abortion care, and prompt treatment of STDs and HIV. So we do know that provision of high quality, affordable sexual and reproductive health is one of the crucial elements when it comes to realizing the rights and well-being of girls and women, and also boys and men. Universal access to effective contraception ensures, therefore, that all adults and adolescents can avoid the adverse health and socioeconomic consequences of unintended pregnancy, while having a satisfying sexual life. Key global initiatives, including the Sustainable Development Goals and also the Global Strategy for Women, Children, and Adolescents, calls for universal access to family planning services to girls and women. So when we come right home, the Ministry of Health has identified provision of family planning as one of the crucial investments for Kenya's health and development. We'll see that in the next slide in a concept which is known as harnessing the demographic dividend. The large size of Kenya's young population and its rapid population growth are influenced by factors like early marriage and early childbearing, the unmet need for family planning, and high total fertility rate. The Ministry of Health is working together with local and international partners with an aim to remove barriers that impede access to family planning information and services by placing more emphasis on improving access to family planning, ensuring there are no missed opportunities, reducing unmet need, and increasing the number of new users. And we'll see this in one of the new outset guidelines that the Ministry of Health introduced in June of this year, and being able to sustain the gains made in improving the uptake of family planning. So as a country, if we are able to reduce the family size and increase the lifespan of our independent population, we could then be able to harness this window of opportunity that economists call the demographic dividend, where we'll have a larger population being able to, to work for the government, contribute to the human capital economic growth. And therefore, when we look at the demographic dividend and its key pillars, one of them is health. So in health, we're saying if we can be able to provide family planning, reduce the number of family size, if we can be able to offer quality healthcare to the citizens and improve on their lifespan, then we could be able to have a larger workforce being able to improve on the GDP. And therefore, you can see why family planning falls squarely if we are to harness this as a country. So some simple definition of terms for purposes of some who have joined in, who are not per se within the medical background. Family planning is being able to get pregnant at the right time, being able to determine the right number of children, therefore being able to prevent unwanted pregnancy so as to have a healthy family where one is able to provide for them socially, economically, mentally, and also spiritually. Contraception, therefore, is the deliberate use of a drug, a device, or a method to prevent pregnancy without avoiding sexual intercourse. Contraceptive use is the ability of individuals and couples to anticipate and attain their desired number of children with spacing off and timing of their births. The contraceptive prevalence rate is a percentage of women who are currently using a method of contraception, regardless of whichever method they have used. Modern contraception prevalence rate will then be percentage of women of reproductive age who are using a modern method of contraceptive at any one point in time. Unmet need refers to the percentage of women who do not want more children or want to space the number of the children that they have, but are not using a contraceptive method. So if you look at some of the statistics that we have as the Kenya Demographic Health Survey of 2014, the contraceptive prevalence rate currently is at 46%. Definitely we could do better. They say this has risen significantly among the married women from 46% in 2009 to 58% in 2014. The use of modern methods of contraceptives among married women from that Kenya Demographic Health Survey of 2014 was 53%. Other surveys have put it at 58% in 2018 and 61% as of 2019. We are waiting for an official Kenya Demographic Health Survey. When we look, despite that, the level of unmet need of family planning still remains high at 18%. So it means that if we have unmet need of family planning falling at 18%, then nearly half of these pregnancies, 49%, will end up in unsafe abortion. The total fertility rate in rural areas like where I work, on average is 4.5, will be higher in certain counties, while in the urban it's 3.1. The teenage pregnancies are still at an all-time high of 18%, but we want to believe perhaps some of the interventions that have been in place may improve this when we look at the next Kenya Demographic Health Survey. As a country, we are committed that by 2030, we should be able to reduce teenage pregnancies to 10% by the year 2025, and to improve on the modern contraceptive prevalence rate to 66% by 2030. So when we look at the modern contraceptive method mix in this country, we can see the injectable contraceptives, which we'll be diving into respective one of them, that's 47.9%, followed by implants at 18.2%, then the pill at 14.1%, followed by IUDs, intrauterine devices, at 5.9%. Sterilization, and this they looked at the female bilateral tubal ligation at 5.6%, and lactational amenorrhea at 0.3%. The male condom use is at 7.9%. So let's look at some of the guidelines that the four cornerstones rather for family planning guidance. So we all are familiar, especially for those of us who provide family planning services, that one of them is the medical eligibility criterion for contraceptive use. And we currently are in the 5th edition as provided for by the World Health Organization. It guides on who can use contraceptive methods safely. We look at MEC 1 to 4 and what each means. The next document from World Health Organization, on the 3rd edition of 2016, is the selected practice recommendations for contraceptive use, which provide guidance on how to use contraceptive methods safely and effectively. Down into our clinics, I know some of us have come across the decision-making tool for family planning clients and providers. Most of the time, we use this when we are providing counseling to our clients. And then lastly, we have the 2011 update, a family planning and global handbook for providers, which generally, in summary, provides guidance on how and who to provide the contraceptive methods safely and effectively. Alrighty. All right, so the medical eligibility criteria usually has 4 criteria. When a contraceptive method is marked as medical eligibility criteria 1, it means that they generally use the method because there's no restriction of the method once you have sampled your client through proper history, physical examination. For any contraceptive method that is marked as MEC 4, then generally that means do not use that contraceptive. Let's look for another contraceptive because it is marked as unacceptable. For any contraceptive marked as MEC 2, so it means that the benefits of using that method outweigh the proven risks. If anything is marked as MEC 3 on the wheel, then it means that that method, the risks really outweigh the benefits, and generally look for another method of contraceptive. So in summary, how to make it simple, if a contraceptive method is marked on the wheel as MEC 1 or MEC 2, then it means you can generally use the method. For MEC 3 and 4, it means look for another method because that method for that client is not appropriate. We'll see with some of the examples as we go into them. So therefore, the objective of this presentation is to be able to discuss various types of hormonal and non-hormonal contraceptives, their mode of action, the expected side effects, their special consideration groups, male contraceptives, other gynae roles of contraception, and areas of research and emerging issues. So we start with the commonest, hormonal contraceptives, also known as steroidal contraceptives. They have been with us since 1956. So some of what we have commonly in the market, we have the oral pill either in a combined or a single preparation. Of the combined preparation, some would mean monophasic. That means you can take the pill continuously for the 21 days, and the dosage in every pill for the 21 days is the same. Or the biphasic pill, where the content of the pill will tend to change from around day 14 moving forward. We have the triphasic pill, where the content of the pill will change after every 7 days for the next 21 days. And we have the emergency pill. Then we have those type of hormonal contraceptives that will only contain one active hormone, commonly the progesterone. And this is where we have the mini pill. We look at this much more, and also the emergency pill, sometimes what we call the famous chocolate among some of our young clients. Then we have the parenteral types of hormonal contraceptives, the injectables and implants. We look at that. We have devices onto which the hormone is coated. So we have a vaginal ring and also a transvaginal ring. We have patches where we place them on the skin, and we have intrauterine devices which we insert inside the uterus. And we're going to be going through these methods. So let's start with the pill. It's one of the most effective and reversible mode of contraception. The ones which only contain one type of hormone will either have levonorgestrel or norethisterone or desogestrel. The generation of progestins right now, we are up to 4th generation, the drospirenone, which is quite good, especially for those clients who have acne, typically commonly used among patients who have PCOS with acne. We want them to benefit from the anti-androgenic and mineralocorticoid action of these hormones. The 3rd generation progesterones have been found to be quite lipid friendly. So the mechanism of action in 4 parts. So one, they would inhibit ovulation. Remember, this has both the estrogen and progesterone, which will work on the hypothalamus pituitary ovarian axis. The estrogen will suppress the follicle stimulating hormone, thereby preventing follicular growth. So that's how we'll knock off that ovulation. The progestins will suppress the luteinizing hormone surge, preventing ovulation. The negative feedback mechanism, it prevents the GnRH production from the hypothalamus. No peak or pulsatile release of follicle stimulating hormone. They will also induce endometrial hypoplasia of a static nature, will make the endometrium non-receptive, as no implantation will take place. They would also make the cervical mucus quite thick, viscid, and scanty, thereby preventing sperm penetration. They also interfere with tubal motility and will alter tubal transport. We know the cilia within the fallopian tube will always beat towards the uterus. So when we are providing combined oral contraceptives to our clients, so if the client is having menstrual cycles or they are switching from a non-hormonal method, then we can be able to switch them at any time of the month. If they are starting within 5 days, then the recommendation is to start within the first 5 days after the start of her menses, and there'll be no need for a backup method. If the client comes after 5 days of her onset of menses, and we have confirmed that she is not expectant, then we can start her on the combined oral contraceptive with a caution that she needs to use a backup method for the first 7 days of taking the pills. So the backup method could be either abstain if she can for the next 7 days, or use a barrier method, the condoms, for the next 7 days. If the client is switching, for example, from an intrauterine device, we can start the COCs immediately. If she's coming where the implant has expired, then we can start the combined oral contraceptives immediately. Please note that the combined oral contraceptives are contraindicated for a lactating mother because we know this will result in reduced breast milk production. And for a client who, for example, has had either a pregnancy loss or the baby has passed on, as long as the first 6 weeks have not been completed, then COCs are marked as MEC4. Now, another thing that we need to educate our clients when we start them on the combined oral contraceptives is on what to do if she realizes she has missed a pill. So if she has missed only one, or let's say one pill, like, well, today is Tuesday, and she realizes that, well, today is Tuesday, she was meant to take her pill probably at 9 p.m. We almost always tend to advise our clients to attach the intake of the pill to a particular activity. Many of the times you want them to tie it around right before they get to bed. So if she remembers tomorrow morning at midday that I did not take my Tuesday pill, the advice is for her to take that pill that she forgot as soon as possible, and to take her Wednesday pill at the time when it's indicated. And there'll be little or no risk. If she misses her pills 3 or more days in a row in the first or second week, the advice is for her to start a new pack the soonest possible and to use a backup method for the next 7 days. If she has had sex in the past 5 days within which she has forgotten to take her pills, she should consider emergency contraceptive pills, and we'll look at this a little bit more in detail when we discuss emergency contraceptive pills. So if she has missed her 3 pills or more pills in the 3rd week, the advice is for her to take a hormonal pill as soon as possible. Finish all the hormonal pills in the pack. If it's a 28-day pill, then she needs to throw away the 7 non-hormonal pills and start the new pack the next day. For those of us who have seen the combined oral contraceptives, for example, Microgynon, the blue or the green pack, there's one which has only 21 pills. So if she has forgotten to take her three pills in her third week, the advice is take your pills as soon as you remember and continue taking the pills continuously. So there'll be no 7-day break for her. And in addition, she will need to use a backup method for the next 7 days. If she has had unprotected coitus in the past 5 days, she qualifies for emergency contraceptive pills before 120 hours are over. We look at in detail on more on that. So when you look at the metabolism of hormonal contraceptives, this slide is important, especially for those patients who are taking other medications, which are enzyme-inducing drugs, and will therefore increase the metabolism of the active content in the combined oral contraceptive pill. So some of these drugs include drugs which we use to treat epilepsy, like carbamazepine, phenytoin. Some of the drugs that we use to treat TB, they are rifampicin and rifabutin. If your patient is on this medication, please alert them on the need to use a backup method if they still want to be on combined oral contraceptives, or if they can, we can switch them to a non-hormonal method. So the medical eligibility criteria for contraceptive use, we can see what falls in category 1, category 2, 3, and category 4. So let's start with category 4, which is the easiest. This means we are not going to use this combined oral contraceptive for this client. So 1, a patient who has severe hypertension which is not well controlled, a patient who has had a history of stroke, a patient who has diabetes with vascular complications, and definitely a patient who has migraines with focal neurological symptoms. Definitely, we're not going to use them in a mother who is breastfeeding, especially if 6 weeks has gestation. And our current recommendation, if 6 months have not ended, the combined oral contraceptive is a MEC4. If a patient is scheduled for a major surgery where there will be prolonged episodes of immobilization, it's good to advise them to inform their surgeon that they are on these contraceptives because of the increased risk of developing blood clots. Then let's switch to category 1. So this is pretty much, we can use them on this type of patients. So it means anyone who is of reproductive age, immediately in the post-abortal phase, if we have significantly rolled out the risk of developing DVT, if a patient has anemia, this works pretty well for them because it will reduce bleeding, as we'll see as one of the benefits. In the patients who are on medication for HIV or who have AIDS, but for them, remember, we encourage dual protection because the use of COCs does not prevent anyone from STIs or HIV. Patients who have had endometriosis, combined oral contraceptives have been used with a lot of improvement on their symptoms. Patients who have dysmenorrhea, patients who have had epilepsy, we have mentioned that. We take a note of the drugs they are using and we advise them that during that time, there will be significant reduction in the active molecule and they will need to be on another backup method. So we said category 2 means we generally can use it, but we can observe as time goes on. So if a patient has diabetes, which is well controlled, hypertension, which is well controlled, just a headache with no migraine, we can use it. Category 3, these days, we're not going to use this unless risk outweighs the benefits and the patient cannot take anything else. And in that case, we should be able to cancel them and even offer repeat follow-ups to be able to guide them around it. So 1, let's start with a breastfeeding mom, postpartum 6 weeks to 6 months, not the very best of a contraceptive to use during this time. We want them to use the mini pill. The one for heavy smokers, some books place it as MEC category 3, some books place it as MEC category 4. As you can see on what is listed under MEC category 3, it's really if there's no other method that you can use, but generally the advice is not to use those methods. So can contraceptives be used for a long period of time without a break in between? The answer is yes, especially so for those women who wish to have menses at the time when they can anticipate them. Probably someone has a wedding which is coming up, and their choice of family planning is contraceptive oral, combined oral pill, or a patient who, for one reason or another, just wants to have menses 3 to 4 times in a year. So for them, the advice is if they get on the 21 daily pill, they will take the 21 pills consecutively for 4 months, then have a break of 7 days, during which we expect their periods to come. So for this, the advice is the 21-day pill consecutively for 4 months, break for 7 days, get your periods, and restart again. So let's look at some of the health benefits of combined oral contraceptives. Well, the ultimate goal is to prevent a pregnancy, and to prevent a pregnancy, some of the benefits are that it's convenient to use, it's not intercourse related, it's reversible. A client can stop using her contraceptive in the month of May, and she can be able to conceive as soon as June, July. When we say it's reversible, it means, well, the return to fertility is quite good. There's good cycle control, especially for ladies who have PCOS. We use it a lot for cycle regularization. It's well tolerated by majority of the patients that we use. It tends to provide an improvement on menstrual abnormalities, especially dysmenorrhea and irregular cycles. It also can be used for clients who have menorrhagia, that's heavy menstrual bleeding, with the improvement of symptoms in up to 50% of them. In clients who have, well, considerable premenstrual syndrome, combined oral contraceptives have been found to offer relief, even for those who have the Mitchell-Schmerz syndrome around the time when they're getting ovulation. It has been postulated to offer protection against endometriosis, uterine fibroids, functional ovarian cysts, benign breast disease, osteopenia, postmenopausal fractures. One, because if it's endometriosis, the use of a combined oral contraceptive, the progestin inside it will lead to the shrinkage of some of these lesions, providing benefit to the patient. Then in terms of prevention against malignancies, it can protect against endometrial cancer in up to 50%, ovarian cancer up to 50%, and colorectal cancer in up to 40%. No major association as of now has been found between combined oral contraceptives and breast cancer. Then conclusions between combined oral contraceptives and cervical carcinoma are not definite. What we know for sure as of now, the use of combined oral contraceptives does not increase the chances of one getting the HPV DNA virus by itself. Perhaps it's due to the increased sexual activities, and also perhaps it's due to the increased sexual activities where somebody wants to have multiple partners. But use of the combined oral contraceptives themselves do not have a direct correlation with cervical cancer. So are there times when we advise on withdrawal of use of combined oral contraceptives? Remember, for the provision of any of these family planning methods, where possible, and I know I'm saying that cautiously because there is a new directive which we'll have a look at, we always want the clients to be able to visit a qualified healthcare provider, have history taken, have examination taken, and therefore we use the MEC wheel to be able to determine if it's a MEC 1 or a MEC 4. However, if with the use of the combined oral contraceptives, the client develops the following: severe migraine, visual or speech disturbances, sudden onset chest pains which worsen with time, unexplained fainting or acute vertigo, severe cramps and pains in the lower limbs, especially the calf region, severe depression, of course, if there's desire for pregnancy, and if they are going for a surgery which will have them immobilized for a long period of time, anywhere from 6 weeks, then that calls for us withdrawing or stopping or suspending the use of the combined oral contraceptive and providing the client with another method of contraceptive which will not put them at risk of developing complications, which we are going to see in a few. So some of the adverse effects of combined oral contraceptives, will start with the minor. There's the nausea, vomiting, headache, and leg cramps, which most of the time will be transient and will resolve after 2 to 3 cycles. But if the leg cramps persist, then we have stated that, and the headaches, that should be an issue and we need to stop that. Sometimes some women will complain of breast heaviness and tenderness with the start and use of combined oral contraceptives. a lot of reassurance on this, and many of the times the clients are able to continue using the method. There's some clients who tend to gain a lot of weight with the COCs, especially I know Femiplan has been indicated for some of these things. If that happens and the client is not comfortable with that, we can always switch to something else. Some patients will develop an interesting mask, like a darkening on their cheeks, like the cloism of pregnancy and acne. The way out with this is to use low-dose COCs or to use combined oral contraceptives, which have fourth-generation progestins. There's some women who will come and report reduction in libido. Most of the time will be due to vaginal dryness, but can remain actually static or can increase due to loss or fear of pregnancy. Where libido has been affected, let them visit their respective healthcare providers that can be addressed. For some women, it will be on the other side, where they have excessive secretion of cervical mucus. And most of the time, we tend to think this is due to a little bit increase of in estrogen. And when that happens, the client comes, we're able to evaluate the discharge. Is it an infective one or a non-infective one? And we advise accordingly. Some of other adverse effects is menstrual abnormalities, mostly the breakthrough bleeding. This tends to settle after 3 to 4 cycles with consistent and correct use. When it happens, one of the things you can try to do is talk to the client. Are they taking the COCs as prescribed? We usually say at the same time every day. Do they tend to vomit after use of the COC? You can actually add an antiemetic to that. Are they using an enzyme-inducing drug, which could actually be altering the levels of the active hormones? If they're missing pills or with a low dose pills, they could be pregnant and it's a miscarriage, either a threatened miscarriage or the full prompts of the miscarriages as we know them. Or is it a lesion which is already existing within the reproductive system and needs assessment? So the way out of this is if they're taking the pills and they tend to vomit, we could either advise them to take the pill as soon as you vomit or add an antiemetic to that until the bleeding stops. Sometimes we give them non-steroidal anti-inflammatory agents. Commonly, we'll use either brufen or mefenamic acid to be able to arrest this for 5 days after a comprehensive examination. Sometimes they could just not have menses completely, and this is due to endometrial thinning out of the endometrium. We do know there's a post-pill amenorrhea, and what this means is the client stops using combined oral contraceptives in January, and she stays for 6 months without getting periods. However, if it persists, the recommendation is for the client to visit a healthcare provider for a proper workup of that amenorrhea. Depression has been found with some of these preparations, and that's why we say if the mental depression sets in with use of combined oral contraceptives, then we withdraw it. Hypertension on the rare cases can develop. If it's not very well controlled, we can always switch them to another method of family planning. Venous thromboembolism, the risk is 3 to 4 times more compared to those clients who are not using combined oral contraceptives. And this is one of the reasons why we need the healthcare provider to be at their point of initiation. Take that history. Is it somebody who's coming from a family that already tends to develop blood clots? Is it a patient who has inherent risk factors for development of these blood clots? Is it somebody who is smoking, are they obese, with poorly controlled diabetes or poorly controlled hypertension? So we switched to a vaginal ring. This is a ring which is coated with the active hormonal molecules. It will have 15 micrograms of ethinyl estradiol. And this is inserted into the vagina, preferably on day 1 of the cycle. It has no effect on cervical cytology and vaginal mucosal changes, and it should be replaced every 4 weeks to allow for withdrawal bleeding. There's less breakthrough bleeding compared to the oral contraceptives because once it's inserted, as long as it doesn't fall through, then we have continuous release of the active molecule compared to the combined oral contraceptives, where sometimes someone may miss an hour or 2 or 3 when they're supposed to be taking them, or they have vomited the active pill when they take it. Another hormonal formulation is the Evra patch. It's a transdermal patch, very, very common amongst the teenagers. It can be placed either on the lower abdomen, the upper outer arm, right back there at the shoulder. I've seen some young girls who actually will have a tattoo that marks the outline of the Evra patch. Will be placed on the bum or the upper torso, excluding the breast. It contains 750 micrograms of ethinyl estradiol and 6 milligrams of norgestrone. We replace every week for 3 weeks. So we advise the client to pick a day for the change of the patch. If she decides it's a Sunday, let's just pick a practical example. If you can go to our calendars. Remember, we always have to make sure either she comes within the first 5 days of her start of menses, where we provide the combined oral contraceptives in whichever formulation, or if you can be able to conclusively confirm that she's not expectant, you can provide this. So let's pick a young girl who has decided that on Sundays will be the day when she changes her patch. So you ask her to mark on her calendar. On the 2nd, she puts a new patch. This patch will stay active till the 9th. On the 9th, she removes the old one, puts in a new one, more or less like an elastoplast that you are changing on a specific day of the week, consecutively for 3 weeks. Then week 4, that will be on 23rd. She stays, 23rd of July, she stays patch free. That's meant to be the week when she should be getting her periods. If the patch detaches, usually we advise on attempting to reattach. And if it's really, really impossible, then she should apply a new patch, but change day remains the same. That means if for one reason or another, that she went swimming or she went to the gym and noticed that it has peeled off a little bit, if you can get the elastoplast, return it a little bit. If it really cannot, put a new patch, but on Sunday, if she's a Sunday girl, remove this patch and put on a new one. I really hope that's clear. So recommendations for when a new patch is forgotten. Remember, we went through this for when somebody has forgotten to take her pill. So if it's in week 1, she should apply the patch as soon as she remembers, but she will need to use a backup method for the next 7 days. If it's week 2 or 3, it depends. Is it less than 48 hours? Then remove the current patch and apply the new one. There will be no need for backup. If she has forgotten it for more than 48 hours, so let's pick our girl who changes her patch on Sunday. For one reason or another, either she forgot to carry it, and a trip maybe out of town and she didn't pack it. If she remembers on Tuesday, then she will remove that Sunday patch, apply a new patch, and will have to use a backup method for the next 1 week. If it's week 4, it's just remove the patch when she remembers, and there will be no backup required. So I really hope that's clear on the on the combined oral contraceptives, because now we are switching gears to part 2 of the hormonal contraceptives, and these are the progestin-only contraceptives. So as the word denotes, this type of contraceptives will only have one active molecule, and that's progesterone. So it could come in the form of a pill. Commonly in the market, we have the mini pill. Mothers call it the microlute. It could come in the form of an injection. Commonly, we have been using the Depo-Provera, but there's a new kid on the block who is known as Cyana Press. We'll see her in a few. Or it could be as an implant, which is either an Implanon or Jadel. It will also come in the form of an intrauterine device, which is coated with the active molecule, levonorgestrel. This could either be Mirena or Avibela. So let's look at the mini pill. So it contains very low dose progestin. It will either be levonorgestrel 75 micrograms or desogestrel 75 micrograms. Its mechanism of action will be by thickening the cervical mucus, therefore inhibiting the penetration of the sperm, thinning out the endometrium and making it very atrophic. This is taken daily at the same time with no break. It's one of those pills that if a mother selects it, you want her to know that if she delays by even 3 hours, a baby could be in the making. So again, tie it down with an activity when you prescribe it. It could be right before I go to sleep or right before I go for my prayers. If it's 8 p.m., it shall be 8 p.m. throughout, because if she takes it even as late as midnight, then the method is deemed to carry a failure rate. Because it has no effect on the lipid, carbohydrate, and clot formation, then it can be ideal for such groups of women. So it's associated with a threefold increase in the risk of diabetes mellitus, especially so in women who had gestational diabetes. Key for us to know, because for our lactating mothers, we usually want them to start on a contraceptive 6 weeks postpartum. It's important for us to always get that history. Did you develop gestational diabetes? If the answer is yes, then the mini pill will not be ideal for them. Then if it's a lady who had a risk of clot formation, then this will be an ideal pill for them. The advantages is that there's no side effects of estrogen, good for lactating mothers, it will have no effect on the breast milk. It's an easy regimen where if we stop, you can easily switch from one to another without any delay. Ideal for patients who the estrogen containing pills are otherwise contraindicated. Those who have hypertension, smokers, those who have diabetes well controlled, or epilepsy, because the progestins have no effect on the enzyme, on the cytochrome P450, which is the one that is used in the metabolism of the medication that manage epilepsy. Remember, we said for patients who are taking the combined pill, this will be an issue as it can alter either the contraceptive content, making the method to fail, or increase the metabolism of the anti-epileptic medication. Therefore, the patient doesn't get well controlled for their convulsions. In patients who have a history of thromboembolism, it will be ideal because of the lack of estrogen. Also, it has been known to reduce the risk of endometrial cancer. The disadvantages, it will cause a lot of breast tenderness. So patients will come through with, breast pain and breast tenderness, and also it will have acne. But if we can use the 4th generation type of the progesterone, this will become better. For women who are using the mini pill, when we do their ultrasounds, we tend to find they tend to develop more of the simple ovarian cysts compared to patients who are on the combined oral. Remember, it's a pill which has to be taken by the clock. And so that's why you're seeing the failure rate of close to 2% because of that. Of course, contraindicated for people who are expectant. We do not provide contraceptives in clients who have unexplained vaginal bleeding till that has been addressed. So we look at the injectable progestins. And I think this from the slide where we showed the uptake of contraceptives, this was actually the leading. So in the market currently, we have the Depo-Provera, which contains depomedroxyprogesterone acetate, and we also have norethistérone and thanate. So for the Depo, I will use that name because it's easier and many people actually relate with it. It is administered once every 3 months if the dose is 150 milligrams. However, please be aware, we also have Depo-Provera, which contains 300 milligrams of depomedroxyprogesterone acetate. If that's the one that you have, then the client will get it once in every 6 months. If we have the norethistérone and thanate, the active molecule needs to be given once in every 2 months. Then we have the new kid on the block, the Cyanopress, aka the sub-Q Depo-Provera. Again, it's given once in every 3 months, contains 104 milligrams of depomedroxyprogesterone acetate. It comes pre-filled. I will show you in a few when we get to that slide. The single dose, single package, non-reusable, subcutaneous, compact, easy to use. And guess what? Clients can actually self-administer it at the comfort of their homes and offices. Again, I'll be able to show you in a few about this. So the mechanism of action of whichever one, whether it's Cyanopress or the Depo-Provera, is to inhibit ovulation, thicken the cervical mucus, therefore inhibiting penetration of the sperm, thin out the endometrium becomes quite atrophic, has no implantation. And currently, we have seen the Ministry of Health giving guidelines. Okay, we'll come to that. Let me not jump my slides. We have seen the Ministry of Health providing a new directive for pharmacists, especially for the clinical pharmacists, to be able to offer over-the-counter injectable, whether it's the Cyanopress or Depo-Provera, with an aim to increase uptake. so that we can reduce the unmet need of family planning from 18%. So let's do a comparison between the two. I don't know, someone can respond to me. Winnie, are you able to see this? Because I have a sample of the Cyana press. It's not something that many of us have used. Winnie, are you able to see this?
We can't see the slides.
Oh, the slides only, but we can see what I'm trying to hold in my hands.
No. Is your video on?
I think so.
I think continue.
Yeah.
You will show us at the end.
All right, so the Cyana press really comes in, it's a pre-filled syringe that you pretty much open the, like the sachet that it's contained in. It's to be given subcutaneously, has a lower dose of the depo-medroxyprogesterone acetate, 104. The needle is about 2.5 centimeters compared to the Depo-Provera, where the injection is 3.8 centimeters. So for the Depo-Provera, it requires the client to actually visit a healthcare provider or even the pharmacies, as the government has advised, for them to be able to get it. But for the Cyana press, especially for continuing clients, it's as simple as visiting their provider, and they're able to get either 2 doses, 3 doses, or 4 doses. Today, I was able to visit the Maristops branch in Meru. What they have as a policy is to issue at least 2 doses for the patient to use at home. So both products are safe and highly effective at preventing unintended pregnancy. They are delivered once in every 3 months. Please just remember, apart from condoms, none of these will offer protection against HIV or STIs. They are comparable in terms of side effects, and both of them are stable at room temperature. So the advantages, and probably why there's been way better uptake of this, that there's easy compliance. I mean, it's just 1 dose and I'm good to go for the next 6 months, for the next 3 months. Safe in lactation, there are no estrogen-related side effects. And for patients who have very painful periods, they actually tend to get improvement on their symptoms, including those who get heavy bleeding. And they benefit from protection against endometrial cancer. Now, for everything that comes with an advantage, the disadvantage. The injectable progestins can come with quite significant amount of weight gains. What I've forgotten to indicate here is the return to fertility can be anywhere from 3 months to a year. And this is always important for clients who are taking them to be aware about. The menstrual changes, of course, we expect amenorrhea, where the periods disappear completely. We usually want to reassure clients it is not a problem if you miss your periods for the 3 months. For some, they'll tend to get irregular bleeding or spotting or prolonged or heavy bleeding. If these two occur, please visit the healthcare provider for that to be sorted. The headache, dizziness can be addressed with some really, I would say, low-cost interventions. Some patients will have low sex drive. Again, these can be sorted with some of the remedies that we have available. So the disadvantages of the injectable progestins is the delay in return to fertility. And this sometimes can be quite discouraging for women because that return to fertility can take up to a year. The irregular bleeding, which we address. We do know there's loss of bone mineral density, especially with prolonged use of Depo-Provera. But once the client stops using the method, this can be reversible. We've talked about the increase in weight, which should be something to watch, especially for women who are at risk of developing diabetes before they develop overt diabetes. So I know this, I'm placing it here, and I will invite discussion from participants. Is it a hit or miss then, given the directive on June 12th that for clinical pharmacists to start providing injectable family planning? Will it actually sort out the unmet need without compromising on the other prongs of care that we provide to these women when they come to the clinic? In Uganda, for example, there is article of June 18th this year, where they were actually telling us that, they give it to women and they self-administer at home. A very important component when we look at in terms of, removing the need to come to the clinic, especially in those centers where road networks really do not exist, or they really have to travel for quite an extra mile to be able to get to the hospital. So let's go to the progestin-based implants. Commonly in the market, we have two. We have actually three: Gynecologist, Implanon, and Levoplant. Gynecologist will have two rods which contain the active molecule, and they are highly effective for 5 years. And please remember, irrespective of the duration of time for which we insert the implants, if you wish to get a baby before the expiry date, you can always come and remove them. That's why we call them the long-acting reversible methods of contraceptives. The Implanon, right now we have the Implanon and NXT, effective for 3 years. NXT part is to enable the implant to be seen on X-ray. Then we have the Levoplant, again, which contains levonorgestrel, labeled for use for up to 4 years. Again, we insert this within the first 5 days of menstrual cycle, immediately post-abortion, and 3 to 6 weeks postpartum, or when we are reasonably sure that the client is not expectant. Due to the fast elimination of the active ingredient from the body once the implant is removed, it assures the woman of an immediate return to fertility, anywhere from a month to 3 months. The lower daily dose that is released to the body gives fewer side effects. One of the common side effects will be inflammation that is associated with bruising when we are inserting the implants. So the primary mode of action is to thicken the cervical mucus, which prevents sperm penetration, would inhibit ovulation also in about 50% of the menstrual cycles, would also result into thinning out of the endometrium, thereby inhibiting implantation. They are quite effective. The failure rate is up to 0.01 woman per 100,000. Some of the side effects will be more or less as with the Depo-Provera. Irregular menstrual bleeding, which could either be heavy bleeding, extremely light bleeding, completely absence of periods, infrequent periods, or shortened or prolonged cycles. Some women, again, will tend to either gain weight or lose weight. Whichever end of the spectrum, if the client is uncomfortable with the weight change, they can always visit their provider for a change in the method. Breast tenderness, mood changes, reduced libido are some of the side effects known to occur with this method. Contraindications will be the same as the one we have discussed with the mini pill. So we have done part 2 of that presentation. Let's go to part 3, where now we discuss intrauterine contraceptive devices, as demonstrated on the image on your right, the device which we're going to place into the endometrial cavity of the uterus. So the objectives is to discuss the copper T and the levonorgestrel intrauterine devices, the principles of insertion, emerging issues and research. This made the presentation be too large. And so unless this is required at a different presentation, will not be addressed in this, the last 3 parts. So let's start with the copper T, which we are very, very familiar with. So it's a long-acting reversible method of contraception, which can be used for 3 or 10 years, depending on the one that the client has selected. So they'll vary in size, shape, and copper content, as we'll see in a few slides. Most of them will have a plastic frame. Again, on your right side, you can see it's called copper T because it's really a T. So the body of this T is mostly a plastic, and you will have copper wound either onto the 2 arms and the stem, and some IUDs will only have the copper wound on to the stem. So difference in policy, availability of the method, the cost, provider beliefs, and user perceptions will influence on the method that is selected. So an example of some of the copper Ts that we have available. So remember, I say that it will depend on the copper content. So we can have this one, which has copper 380A, will work for 10 years. The same type of IUCDs, this one has just made it fancy for us to be able to insert it with the no touch technique, is actually the one which is in column 3. You can see the copper wound on both the arms and the T lasting for 10 years, 380A. We also have the sleek type of the IUDs. We have the 375, which would work for 5 years, and we have the 250, which will work for 3 years. It's the copper content that determines for how many years can we use this copper IUD. Then we have the copper 380, where the copper instead is simply wound onto the stem. You can see the arms are still empty. These are plastic, would work for 5 years. And again, we have this one on the extreme right, which is ideal for placement immediately post-delivery. So the mode of action is by inhibiting fertilization due to the toxic effect of the copper ions, because it's spermicidal. The spermicidal activity is increased by the levels of copper ions, the prostaglandins, which will be increased due to the inflammatory response, and to the white blood cells, again, from the inflammatory response. It will prevent implantation by that local inflammatory reaction in the endometrium. The increased copper ions in the cervical mucus will inhibit the sperm's motility and viability. So remember, we say this is purely non-hormonal. So the mechanism of action is purely from the copper. The effectiveness is extremely effective. This does not rely on user compliance. Once fitted, it's expected to work. The failure rates for most of these devices are quite low. It's 1 to 2% at 5 years. And there's always that risk of expulsion, especially in the first 6 months following insertion. And we always tell clients, first 3 to 6 months, your periods are likely to be heavier than usual. You're likely to be crampier, a little bit more than usual, but always come back if that happens. We give you medication. We manage that, because once you're able to go through the first 6 months, the coil can give you benefit for 3, 5, 10 years, depending on which has been picked by the client. So it's actually indicated for any woman who is seeking contraception. And the word is actually any woman, because it barely has the contraindications of whether it's estrogen or progesterone. So for any woman who's above the age of 40, can actually be left in situ until menopause. And for some clients, they actually stay with it years and years post menopause. It's appropriate for use for those women for whom estrogen has been marked as a contraindication. The women who develop migraines, those who have diabetes or epilepsy or develop DVT. It can also be used for emergency contraception. We'll see that in separate slides. So make 4 indications for use of the copper IUDs. That says we're not going to use this method at all. Of course, if one is expectant. If there's any pelvic infection, puerperosepsis, post-septic abortion, pelvic TB, current pelvic inflammatory disease, or current cervicitis, the insertion of any IUD device is contraindicated. Of course, at the initiation, if a patient is on workup for unexplained vaginal bleeding or refined cervical cancer or endometrial cancer, we cannot initiate a copper IUD, would offer treatment instead. For patients who have uterine fibroids, especially the submucosal type, and also some of the intramural that will have to have a larger component into the submucus, distorting the endometrial cavity will not be ideal candidate for insertion of any intrauterine device. So benefits of IUD over and above pregnancy prevention. It's a long-term method up to 10 years, depending on what has been picked. It's discreet, it's extremely effective, cost-effective for long-term use. The only cost you'll incur is at the insertion. Once everything is nice and good, we'll see you after 10 years, if it was for 10 years, after 5 years or 3 years. Rapid return to fertility after removal, because it was non-hormonal, can be inserted anytime during the menstrual cycle, as long as we have really confirmed that the client is not expectant. And remember, it can also be used as an emergency contraceptive, can be used immediately after abortion or delivery. So after placenta is delivered, the next thing we actually do for a client who has selected is the postpartum insertion of an IUD. Again, because it's a hormone-free option for women who otherwise have been ruled out for use of hormone-based contraceptives. The disadvantages definitely will require a visit to a trained healthcare worker for insertion and removal. There's that small risk of expulsion within the first year due to the body initially trying to sort of expel it. You know, that's why you have the increased heavy menstrual bleeding and worsening dysmenorrhea within the first 3 to 6 months. As have indicated, it does not protect against STIs and HIV. There will be that worsening of dysmenorrhea, I've mentioned that. Altered or abnormal bleeding. For some women, they will tend to spot for quite a significant period of time. We can use easy remedies for this, ibuprofen or mefenamic acid for this. Perforation, especially if you find somebody who's quite enthusiastic, especially post-MVA, that uterus is very, very friable. And so you actually need someone who's not very, very enthusiastic. Please note that if you're inserting the IUD after an MVA, really don't sound that uterus. The risk of ectopic pregnancy, relative risk, quite still low. There is also the risk of pelvic infection if it was not aseptically inserted. And that's why, let me go back to this slide. Some of these providers have actually come with a safe load technique for us to completely use the no touch technique of the IUD so that our women do not develop any pelvic infection. So I hope that's clear. So I think now we should go on the part 4 of this presentation. So we are going now to discuss methods of emergency contraception. So once we have done the counseling and offered the family planning method that the client has selected, it is upon us to always discuss methods of emergency contraception in the event the contraceptive method fails. So granted, there are no restrictions for the MEC on who can use the emergency contraceptive pills. And I hope that's a little bit much more clearer. If a client comes and says the condom broke, we do not take them through the MEC eligibility criteria to determine which method works for them. That's because the assumption is it is a single event and not a consistent method that someone is going to be using month in, month out. Granted, one can have an emergency once a year, but for clients who we note there's repeated use, then we are going to offer them counseling for them to know the available methods of contraceptives which they can take and not the emergency contraception. So mifepristone is a competitive inhibitor of progesterone. It will muffle the effect of progesterone and thereby inhibit implantation. The doses which have been used, you can see it's quite a range of 10 milligrams to 600 milligrams taken within 72 hours of intercourse. It's actually one of the highly effective methods with a pregnancy rate of 0.06%. Ulipristal acetate is another progesterone inhibitor. Will be used as a single dose of 30 milligrams, will suppress follicular and endometrial growth, thereby delaying ovulation and inhibit implantation. Pregnancy rates of about 1.2%. Then we have the favorite weekend chocolate, the emergency contraceptive pill, the P2 as we know it. It contains levonorgestrel, these 2 tablets that you can see over here. They can be taken in 2 ways. We either take the 2 tablets at once, and we usually take them before 5 days are over, following the either condom failure or unprotected sex, or you can choose to take 1 tablet 12 hours apart. The mechanism of action will be to inhibit the luteinizing hormone surge. Therefore, there will be no follicular development, and therefore there will be no ovulation. Please note, this will not work if implantation process has begun. The other way of using emergency contraceptives is the regular combined oral contraceptives. They can be modified in terms of the number of pills we take for them to work. So this is actually what we call the USP method. The goal, whichever brand that you have, is to deliver 100 to 120 micrograms of ethinyl estradiol and 0.5 or 0.6 of levonorgestrel, or 1.0 to 1.2 milligrams of norgestrel. And these are usually taken 12 hours apart. So I've given an example that if it's microgynon that we have, then we'll take 4 tablets immediately and 4 tablets after 12 hours. When you look at the USP method and what it's trying to deliver, you realize then that Yasmin cannot be used as an emergency contraceptive. Because this will give a lot of nausea and vomiting to the patient, the advice is let's get an antiemetic to use 30 minutes to 1 prior to taking the 4 tablets to minimize that. Pregnancy rate of 1.2%. Intrauterine devices can lastly be used as a method of emergency contraception. And the advantage of using these methods is if I'm in this emergency setup because I was not using a contraceptive method, then once it's inserted, it becomes a family planning of choice and it would work for the number of years selected. So for a long time, what we have known is that the copper-bearing IUDs have been the devices of choice, but the levonorgestrel IUDs can also be used as a method of emergency contraception. Please remember all of them, the 5 we have discussed, should be used ideally within the first 72 hours and definitely before 5 days of unprotected coitus. So what are the indications then of emergency contraception? One, definitely where there has been sexual assault or rape, and we encourage our clients or the people that we are on this call if this happens to anyone, they need to know that it's part of the GVRC package. Where there has been contraceptive failure, either the condom broke or those slippage or incorrect use, where somebody has missed 3 or more consecutive of the combined oral contraceptive during the first week of the cycle. If a client who is on the mini pill has missed more than 3 hours of the usual time of their intake. If it's a patient on the injectable, if it is the norethisternol and Thanet, which we give every 2 months, if she's 2 weeks late. If it's a client either on Depo-Provera or Cialis Press, if she's more than 4 weeks late. If it's a patient on the combined injectable contraceptive, if she's 7 days late. For the clients who really want to use the withdrawal method, if that has failed. For the client who was using the calendar or the rhythm method, if there has been a miscalculation of that. If there has been expulsion of the IUCD or a missed pill and the rest, then emergency contraceptive is called for. So the male contraception, I do know this, the uptake on it has been quite low. This is for us to know that some of these methods are being used. So testosterone combined with progestin has been found to suppress sperm production. Testosterone and decanoate has also been found to be successful. Unfortunately, for most of these molecules that I've listed here are barely being used in this country. Probably Kigondu will tell us, why don't you want to take one for the team? And that marks the last part of my presentation. Thank you very much.
Okay, thank you. Sorry. Thank you so much, Dr. Kanyi, for the very informative session. You have really tried, because this is a wide topic and you have covered it comprehensively. We have a number of questions. I suggest we do just 5 minutes on question and answer, then we move on to our sponsors. We'll give Victor an opportunity to speak to us about the products they have at Mary Stopes. So the first question we'll take, I'm seeing 2 people have asked about the Chinese pill. So kindly comment about the Chinese pill. Yeah, so there's something else about the Chinese pill. I can't see the that question. And then the second question is on extended use of COCs. Should one expect heavy bleeding during the breakthrough bleeding? And then there are 3 questions on libido. One person is asking about the best treatment for low libido, for loss of libido. Another one is asking about how to handle women who come to the outpatient with complaints of low libido. And there was another question still linked to libido. Probably you can handle those 3 first.
All right. Thank you so much, Dr. Winnie. So on the Chinese pill, let us be clear that it's not something that the Ministry of Health has approved. We know that as a fact because the same molecule has not sealed down, for example, in the county hospital.
Dr. Kanyi, you're not audible.
Oh, sorry about that. First of all, thank you for the questions. The Chinese pill is not an approved method of family planning as approved by the Ministry of Health. We know that as a fact because the same cannot be found in any of the government institutions. It's something of concern because the women who tend to use it, granted, they will tell you that they find it, comfortable to use as a single dose, but after several months of use, they come with heavy menstrual bleeding, and some actually come with infertility, where despite working them up, we actually mark them as a known cause for inability to conceive. So definitely not something that we are encouraging our women to take. We can only postulate content. We do not know what it contains. And if we can just probably look at the arm in which it's meant to work, we tend to think it contains very large amounts of estrogen, for which the effect sometimes is what you start seeing with heavy uncontrollable bleeding. So my take on that, not something that I would advise anyone to use. So on the extended use of combined oral contraceptives, should one expect heavy bleeding during the break? It boils down to a particular set of patients. But many of them, they will say their periods will actually be more or less the same. They'll last anywhere from 4 days to 7 days, and they have not been described as heavy. And the clients who use it have been motivated to continue using the method because the bleeding is not as much. Now, for the management of libido, many of the times we try to offer psychosocial counseling to the couple. Are there any issues that could be there? If everything is fine, we have some molecules that are in the market that can be used. One of them is Desirol. The other one is Visnadine. The others is lots of chia seeds. Others is ashwagandha and some of these things. That handles the 3 set of questions you have thrown my way. Back to you, Winnie.
We have a number of questions. Let me see how many we can handle because of time. We have questions on cyan press. How is the use of cyan in lean women? Are the drug pharmacokinetics affected when there's minimal subcutaneous fat? And then is there a cutoff age for depot? And then on IUD, is the use of IUD advisable in nulliparous women with frequent UTIs? Then there's another one on Mirena and always having brown discharge close to every week. Is this expected? Does it need to be changed? Still on IUD. Pregnancy with IUD, is there any effect on fetal growth or causes fetal anomaly? Maybe we can address those first. Sorry, let me add a fourth one on IUD as well. Does the copper IUD offer immediate contraception, or in what duration of time does copper cause toxicity?
All right, thank you for that. So we'll start with the first one where somebody asked, is there an age where you can offer contraceptives or not? I'm very keen on the National Reproductive Health Policy that was being launched today, because what is clearly indicated in that document is that we cannot provide contraceptives to under 18. Very clear on that, despite the teenage pregnancy burden being high. So I hope that is very clear. Then IUCDs can comfortably be inserted in the nulliparous woman very easily. Many of the times what happens when the client comes in, we tend to give them some little bit of misoprostol, just 200 micrograms, and then now try to see if you can be able to sound that uterus. There's not been a problem for a nulliparous client. Now, the same participant has asked if somebody has recurrent UTIs, can we still use the IUDs? The urinary tract infections have no correlation with the insertion of the intrauterine devices. The only time, as per the presentation, is that if there's any active pelvic infection, the cervicitis, pelvic inflammatory disease, or pelvic TB, that's the only time we do not insert an IUD. The urinary system is not a contraindication for use of intrauterine devices. For the participant who is mentioning that she has a brownish discharge every week post Mirena use, my recommendation and advice will be if she can visit a healthcare provider soonest for proper evaluation. Many of the times, I think that's the way to go before we start telling her to use brufen or mefenamic acid. Let her have a comprehensive evaluation. She'll be advised from that. yes, there are some women who have conceived while on either of the methods that we have mentioned. One of the participants has raised a question on if a client gets pregnant with the IUCD in situ, will there be increased fetal anomalies? The answer is no. The only expectation with those pregnancies is that sometimes they may tend to have either threatened miscarriage. Many of the times they'll manage. There's room for removal of the IUD, most of the times in the first trimester, very, very cautiously. But in terms of fetal abnormalities, the answer is no. And many of the pregnancies have continued even with the IUCD in place, and the ladies have delivered at term. It's baby on one side and the IUCD on the other one. Then the question on when the copper IUD would be active, remember for these methods of contraceptives, if you're offering them after 5 days of the onset of menses, the client should expect protection after 7 days. And that is why after administration of any of the methods of contraceptives, if it's after 5 days of the onset of menses, but we have excluded pregnancy, the advice is to always use a backup method, which is either a condom or to abstain. I think I've finished those set of questions you've thrown my way, Dr. Winnie.
We are privileged to have our newly elected president for Kenya Medical Association, and we can see that he's actually hit the ground running. He's been in all he's been in the vital meetings for reproductive health and
Have we lost Winnie?
yes, Dr. Kigondu.
Oh, have we lost you? Or you? I thought you had lost.
You're gone.
Oh, thank you very much. And I really appreciate Dr. Grace Kanyi for a fantastic presentation. I think everyone in the webinar has actually appreciated. They really thought they knew about family planning and contraception, but today they have been taken to school by Dr. Grace Kanyi. Thank you very much, Dr. Grace Kanyi. We also want to thank Victor for his support for this particular webinar, and Dr. Winnie and Dr. Soy for their fantastic support that they have done for this webinar. We also want to thank Peter Ogero for providing the Zoom platform from KMA. Thank you very much. Indeed, today I was at the launch of the National Reproductive Health Policy 2022, and this is to encourage each and every one of us to interact with the document and see where we plug in as reproductive health experts. We need to interrogate it and give our views through Kenya Obstetrics and Gyne Society so that we continuously take charge of reproductive health in this country. KOGS Central is taking the lead in Central in running webinars in trying to improve the welfare of obstetrics in the Central region, which goes all the way from Machakos to Meru up and through to Kiambu, Murang'a, and all. And we want to thank you all for attending this particular CME, and we'll be inviting you for many more. This particular presentation will be present in the KOGS YouTube page, and you can always go over and over and over again, because I don't think you can understand all those things in one sitting. And with that, I hand back to Dr. Soy. Thank you very much.
Thank you, Dr. Kigondu. And thank you to Victor for the facilitation for this CME. I'd also like to extend a very warm thank you to Dr. Kanyi for the wonderful presentation. I think we all appreciate. And to the attendees, thank you, and you're welcome for many more CMEs to come. You can go to the KOGS YouTube page to check out this CME. and the previous ones, all CMEs will be uploaded to the KOGS YouTube page. Your CPD points will be uploaded to you, will be sent to your email, so be sure to check out for that. And thank you for attending. Have a good night.